I am Burdu Shekeva. I am a teacher of the Kyrgyz State Medical Academy. Today we will speak about disseminated tuberculosis. Let me share the screen with you. Here we go. Let me expand the screen. All right. Disseminated tuberculosis, including miliary TB, is usually a consequence of the lymphangiomatogenic spreading of TB infection. It may affect as children as adults and may be a single form of TB as a complication of other clinical forms. How do we classify the disseminated TB? There are different classifications, and now we will speak about the classification by the clinical features. So it could be miliary TB or acute disseminated TB with the different forms: pulmonary, typhoidal, meningitis, acute tuberculosis sepsis, and also there are subacute disseminated TB and chronic disseminated TB. By the pathogens of the disseminated TB, it could be primary or secondary TB. By the way of mycobacterial tuberculosis spreading, it could be hematogenous, lymphogenous, bronchogenous, or it could be mixed spreading. For instance, lympho and hematogenous or lymphobronchogenous. By the volume of the affected lung tissue, it could be limited process or widespreading process. Let's speak about miliary TB. Miliary TB is a consequence of the hematogenous dissemination, which usually occurs during the early phase of tuberculosis infection. Miliary TB is more frequent in children and infants, but may develop at any age. Milium, it's a word from Latin word, it's millet, because tuberculosis nodulae, they look like millet seeds, like grains in the chest X-ray. Miliary TB is generalized massive infection characterized by diffusion of bacteria through the body. The disease may manifest as a miliary pattern of very small nodular elements or millet seeds in the lungs. It can occur immediately after primary infection or during reactivation of the latent site, and it is thought to occur during a hematological spread. Pathogenesis and pathomorphology of the miliary TB. On the right side, you can see the lung tissue on the autopsy. So on the autopsy, the millet, disseminated TB looks like millet grains. They have mainly productive reactions, so their borders are clear, but they don't fuse together and cavitation don't form. So miliary foci are located in subpleural areas where there is a highest number of the blood capillaries. The source of hematogenous spreading of TB infection is usually tuberculosis of the lymph nodes. Caseous necrosis can rupture into bloodstream, so mycobacterial tuberculosis spread and enter into different organs and tissues. Then mycobacterial tuberculosis can cause allergic changes of the blood capillaries wall. It lost its smoothness, becomes rough and penetrative. So mycobacterial tuberculosis sit down on the capillaries wall, and then they enter into intestinal space through the vessels wall. Tuberculosis granulomas form in the capillaries wall and the interstitial tissue. The main clinical forms of the miliary TB is acute tuberculosis sepsis, its pulmonary form, typhoidal form, meningitic form of the, or it could be tuberculosis meningitis. The classic acute form is mostly found in children, in young adults, or immunocompromised or HIV patients. The presentation can be either abrupt or insidious, marked by a progressive deterioration of the patient's physical condition. The clinical picture is often completed within 1 or 2 weeks, and is characterized by a profoundly altered physical condition, marked wasting, headache, and constant high fever. Discrete dyspnoea and coughing suggest a pulmonary focus. However, lungs can often be clear on auscultation. A moderate hepatosplenomegaly is occasionally found. By the clinical picture of the acute tuberculosis, sepsis characterized by the most severe generalized form of the miliary TB. It usually develops in infants or immunosuppressive patients, especially HIV. The disease usually begins suddenly with strong dry cough, chest pain, high fever, up to 40 degrees and more, cyanosis, severe symptoms of general intoxication, breathlessness, and intoxication increase. Outcome may be fatal after some days. Miliary TB. Given this non-specific clinical picture, typhoid fever and septicemia should be considered in a differential diagnosis. Diagnosis of miliary TB is confirmed by chest X-ray, and generally, the sputum smear examination could be negative. When there is no possibility of obtaining chest X-ray, the lack of response to broad-spectrum antibiotic is an argument in favor to miliary TB. Clinical picture of the acute tuberculosis sepsis. Diagnosis is usually confirmed by pathomorphological examination. Miliary foci are usually found in many different organs, in lung, pleura, brain, liver, spleen, and kidneys, as you can see on the picture on the right. Clinical picture of pulmonary foci. So there are chest pain, dry cough, or little of sputum, breathlessness, cyanosis, high fever, weakness, sweatness. Symptom of the lung infection is predominant. On percussion, you can hear tympanitis. On auscultation, bronchial timbre of breathing, sometimes a little of fine moist rays or wheezes may be heard. Severe intoxication is similar to typhus. So this form is called typhoid. Patient has got pulmonary symptoms, but severe symptoms of intoxication is predominant. Liver dysfunction, consciousness abnormalities, delirium, hallucination, infection psychosis, cramps, collapse, and even toxic shock with fatal outcome. On the chest X-ray of the miliary TB, we can see diffuse bilateral or interstitial changes of lung picture occur during the first days. Then diffuse small miliary foci appear in chest X-ray film after 10-14 days. Mediastinal enlarged lymph nodes may be also detected, especially by the computer scan. You can see on the picture the example of the chest X-ray of the miliary TB. Miliary TB is always a medical emergency. In children, the higher risk of the meningeal involvement is it's in 60–70%. Lumbar puncture should be routinely performed if miliary TB is suspected. The TST test is more likely to be falsely negative than any other forms of TB. Subacute disseminated TB, the pathogenesis and pathomorphology. The source of lymphohematogenous spreading of TB infection is usually affected lymph node. Mycobacteria tuberculosis enter into bloodstream. They carry it into the lung tissue and cause formation of focal specific lesion. Exudative and alternative inflammatory reaction predominate, so focal lesion can fuse together and cavities in the lung tissue form. Pleura, kidneys, bones, joints, gastrointestinal tract, and other organs may be also involved in the process. By the clinical forms, also they are varied and they are numerous. They can simulate a lot of different diseases: acute and chronic bronchitis, pneumonia, exudative pleurisy, acute respiratory viral disease, or any infection disease such as typhus, or paracaryosis, and etc. So different organs other than lungs can be involved in the pathological process too, because lymphohematogenous spreading of infection takes place. In this case, TB process may simulate some spinal disease, like a cervical or lumbar spondylosis, even radiculitis, prolapse intervertebral disc, renal and urinary tract diseases such as nephritis, tumor, urinary stones, etc. Also peripheral lymphadenopathy, such as sarcoidosis, lymphogranulomatosis, lymphoma, etc. So the differential diagnosis may be very difficult in this form. This is the pathomorphological on autopsy, the case of the intrathoracic lymph nodes disseminated TB when the intrathoracic lymph nodes involved. So you can see the millet seeds in the lymph nodes. Here is the lungs on the autopsy, how they look like. So you can see the millet seeds in the lung tissue. It is a generalized process. On this here, you can see the kidneys. This is the autopsy of the kidney, and the millet seeds you can see on the picture. This is the case of the generalized subacute disseminated tuberculosis when the mesenterial lymph nodes are involved. You can see the millet seeds in the mesenterial intestines in the lymph nodes are enlarged, and you can see that they are not so big. They look like seeds. Here the on the intestine, so you can see the lymph nodes also. Speaking about the chronic disseminated TB, its all focal lesions are different from each other because they are at different stages of their development. Oldest of them are calcified, some of them are dense, and new fresh foci usually have area of perifocal exudative inflammatory reaction. There are TB cavities in the lung tissue. Fibrosis, sclerosis of the lung tissue is getting much expressed year by year. On the pathomorphology, on the autopsy, in patients with chronic disseminated TB, the spreading of infection is indurative. When the wave of lymphohematogenous spread occurs, new focal tuberculosis lesion in the lung tissue appear. So you can see different stages of the tubercular foci are developed in this lung. So you can see the cavities, and you can see small millet seeds. So different in the different stage of the development of the tubercular foci. Clinical picture of the chronic disseminated TB. The main complaint in patients with chronic disseminated TB is shortness of breath or breathlessness. It is getting stronger year by year. Other pulmonary complaints such as cough, sputum production, chest pain don't express strongly because the body is adapting to this condition. The disease has indurative pathway, increasing of temperature, loss of weight and appetite. Weakness usually takes place during the exacerbation of the disease. There are dysfunction of endocrine and nervous system in some patients with chronic disseminated TB. How to diagnose of the disseminated TB? Well, it is the main feature. It's a main sample, it's sputum. So we do perform sputum tests such as gene expert and microscopy, where we can find the detect Mycobacterium tuberculosis. Then the sputum microscopy with Zell-Nielsen staining is usually positive in patients with subacute disseminated TB. Sputum tests allow a rapid and reliable identification of patients with pulmonary TB, and they are mostly smear positive. But if the number of the bacilli is lower than 5,000 in mile, it could be smear negative. Molecular or genotypic tests can be used to diagnose TB through the amplification of nucleic acid or DNA or RNA. So they are also used to detect drug resistance through identifying genetic mutations. So in the previous slide, we spoke about the GeneXpert. So different assays and platforms can be developed. So these tests can diagnose TB and resistance to rifampicin. In contrast to other techniques, in vitro culture, DST, and conventional molecular techniques, the GeneXpert can be used in peripheral laboratories and doesn't require sophisticated equipment or highly skilled personnel. So GeneXpert MTB it has a good sensitivity, so 80% of the sensitivity and specificity. So if the patient has MTB in the sputum, so you will definitely find it. And GeneXpert could be performed in any fluids, such as cerebrospinal fluid, lymph node material, and also gastric fluid. Because of its excellent performance, its quick turnaround time, and it's easy to use, this test should be used as an initial diagnostic test in all patients, especially in HIV-infected patients, and especially when the multi-drug resistant TB or TB meningitis are suspected in both adults and children. There is another different assay, which is molecular and also rapid. It's line probe assay. So there are two types of the line probe assay for these first line and second line drugs. So the name of this assay is genotype MTB DR plus assay and genotype MTB DR second line assay. So this assay detects MTB as well as resistance to rifampicin and isoniazid for the first line drugs, and for the second line drugs is fluoroquinolone and second line injectable. So the culture allows diagnostic confirmation of TB and is more specific than the microscopy. So with the but the disadvantage of the culture is the time. Yeah, so you have to wait for 2 months to get the DST result and the culture result. The TST test is also informative, but mostly in children. It doesn't. We don't use it for the adults in our country. So on the chest X-ray of the subacute disseminated TB, the focal opacities are detected, and they are usually located in the both lungs. They are often heterogeneous. They have different sizes. They can fuse together, but all of them have the same intensity. TB stent-like cavities with a thin wall are often detected in upper parts. Sometimes accumulation of the fluid in pleural cavity may be detected in the chest X-ray, as you can see on the picture on the right side, the lower picture. In the chronic disseminated TB, it was mentioned above. So there are polymorphic focal opacities in chronic disseminated TB. All foci are in the different stages of their development, so they are different from each other. Calcified foci have clear outlines, very high intensity, and fresh foci have unclear borders because there is area of perifocal inflammation around them. There are cavities and signs of fibrosis, loss of volume of affected lobes, deformation of the lung root, formation of the pleural lesions, dislocation of the mediastinum, and so on. So many different changes you can see in the chest X-ray. And you can see this one of the as example on the right side, the chest X-ray picture. So of course you have to differentiate the disseminated TB from the other diseases, and these diseases could be pulmonary disseminated carcinoma, or non-tuberculosis granulomatosis such as sarcoidosis, lymphogranulomatosis, alveolitis, and etc. Also, you have to differentiate with the professional diseases or diseases of connective tissue. It is difficult, in difficult diagnosis cases, diagnostic thoracotomy with the lung tissue biopsy may be necessary to confirm the diagnosis. So the treatment, Treatment prescribed according to the drug sensitivity or drug susceptibility test results. So they could be drug sensitive TB and drug resistant TB. And according to these DST results, you prescribe a treatment. Also symptomatic treatment, if there is a intoxication, so you have to deal with the intoxication, even you can use a hormone therapy. So there could be complications such as hemoptysis or any other complications. So you have to treat the complications also, and the treatment can have different prognosis. It could be treated or it could be fatal if you miss the acute phase. That is all. Thank you very much for your attention. Thank you. Bye.